If you're not yet a member, go onto the website. Membership is free. And membership gets you access to a members area where there'll be a video recording of today's meeting and also access on there to previous meetings. The Society produces newsletters, and you can find those on the website too. On the website, there'll also be information about the joint sessions with Myeloma UK, the info sessions, and also some information about the webinars and seminars organised by Guy Pratt. So the way that we organise these meetings is by feedback. So please fill out the feedback forms at the end of the session. The feedback forms are read by an educational committee. So if you'd like to be part of the educational committee, then do come up and speak to myself and Jonathan at the end of the meeting, and you can get involved. So just moving on to this year's myeloma meeting. We've titled it today, Myeloma Management Beyond the Drugs, and that's because feedback from previous sessions has suggested that you want to hear a bit more about supportive care, how best to support your patients in clinic. So in the morning session, we're going to focus on bone and spinal disease, after which we'll have some coffee, and then we'll hear from our bursary winners. Before lunch, we'll hear from the Michael Morley lecture, which we're delighted to welcome Professor Heinz Ludwig all the way from Vienna, and he's going to be speaking about infection management in our myeloma patients. Over lunch, there'll be the AGM, and then our scientists will break off into the Portland suite, which is just the room where the breakfast was held, whilst the rest of us go into a meeting on quality of life and end-of-life treatment decisions. There'll be afternoon coffee before we go into our valedictory speeches, and then the meeting will end. So I really hope that you enjoy today's meeting. I'm now going to hand over to Neil Rabin and also Catherine, who are going to give us a UK clinical myeloma update. Thank you.
So thank you very much. So we're going to give a clinical practice update. It's myself, consultant haematologist at UCH in the North Mid. So I'm going to talk about some of the pathway changes that have happened over the last year. Then Sarah Henshaw will follow on from that with a nursing update. And then finally, Catherine Lugerin will talk about some pharmacy issues. So just in terms of the clinical practice update, I was going to go through what the current treatment pathway is, which is clearly complex, but clearly evolving over time. Talk about some recent changes in terms of the approvals, some upcoming NICE appraisals and also CDF appraisals. Talk about some future treatments that are on the horizon. And then I think it's really important that we communicate the fact that as the UKMS, as has been mentioned, advocacy is a really important part of our role. And I'll talk briefly about how we advocate on behalf of the clinical community to get access to drugs for our patients. So this is the pathway that I'm sure people are aware of. We talk about different lines of treatment. This is very much dependent upon NICE appraisals that have happened in the past. And you can see as you go across the slide, you go from first, second, third, and fourth line. And you can see in first line, the current pathway would involve Dara VTD prior to stem cell transplant, followed by some consolidation and then lenalidomide maintenance. And then in the non-transplant eligible population, probably the biggest change is within the last few weeks, we're very fortunate that we now have access to daratumumab, lenalidomide, and dexamethasone for our non-transplant eligible patients, and I'll talk about that briefly later. We still have other treatments available, such as lenalidomide and bortezomib. In terms of second line, we have a raft of different treatments which are available. Daratumumab, bortezomib, dexamethasone has gone from the Cancer Drug Fund and is now part of routine commissioning. And you can see that we have a range of treatments, including a daratumumab-based, carfilzomib-based, lenalidomide-based, and of course we should always consider stem cell transplant as a salvage for those patients at second line. And then in terms of third line, I think it's important for the audience to be aware that ixazomib, lenalidomide, dexamethasone has successfully exited the Cancer Drug Fund and again has gone into baseline commissioning, and that is available at third and fourth line. And of course, we have a range of treatments available at fourth line. So the biggest change, I think, for us in terms of the clinical community over the last few weeks is the introduction of daratumumab, lenalidomide, dexamethasone for newly diagnosed non-transplant eligible patients. And this is based upon the really impressive MAIA study. And you can see that there were over 700 patients who were randomized 1-to-1 between dara-len-dex and len-dex. And this is the trial that was reported in the Lancet, and you can see that there is a clear improvement in both progression-free survival and also overall survival. And actually, for those patients on the Daralendex arm, we're talking about a PFS of around 4 years, 3 to 4 years, which is clearly very, very impressive. And this has led to the approval for Daralendex within the last few weeks. So I think this really is a game changer for the non-transplant eligible patients. In terms of other approvals, as I've mentioned, daratumumab, bortezomib, dexamethasone has come off the Cancer Drug Fund and is now NICE approved. The blue tech form is essentially quite complex, but essentially it means that there is no difference in the availability. So the same groups of patients that we would give Dara, Bort, Dex on the Cancer Drug Fund is exactly the same as we're able to do now. Ixazomib, lenalidomide, dexamethasone was available at second and third line previously due to COVID planning rules and also on the Cancer Drug Fund. It's now available at third and fourth line through having exited the CDF onto the NICE pathway. And then finally, I think some of us have struggled in terms of being able to give bortezomib weekly, and we've been, in a way, forced to give, as per license, bi-weekly bortezomib. And from what I understand, NHS England are more comfortable with us actually giving weekly bortezomib rather than twice-weekly bortezomib. In terms of up-and-coming appraisals, we're very fortunate that there are new drugs now available. So in terms of the BCMA-directed therapies, belantamab is going through a current ongoing appraisal. That's the antibody-drug conjugate. Elranatamab and teclistamab are both going to be appraised by NICE, hopefully next year, the bispecific antibodies. CAR-T, both the Citacel and Idacel aren't currently going to be going through the NICE appraisal process, but hopefully in the next 2 to 3 years we should hopefully be able to access CAR-T. And of course there are other BCMA, GPR5CD and other targets which are in the pipeline. In terms of other upcoming appraisals, we've got isatuximab, pomalidomide, dexamethasone, which is currently on the Cancer Drug Fund, and that appraisal is due, I think, in January of next year. And then we've got other potential appraisals, which again are going to happen in the new year or early next year. We've got selinexor is going to NICE, hopefully early next year. And then we've got other combinations with 38 monoclonal antibodies, isatuximab and daratumumab, which are coming down the line. I think it's important for people to realize that a lot of appraisals may not necessarily proceed, and that's very much dependent upon whether the company wants to take it to NICE. And sometimes you'll see that things are licensed, but they haven't proceeded because the company has decided to withdraw or suspend the appraisal. I think it's important to talk about the role of advocacy on behalf of the UKMS. We do our best to advocate on behalf of the clinical community. We deal with both NICE and CDF appraisals. We liaise with our partners in Myeloma UK and also industry appraisal partners. And obviously we appeal if there are negative outcomes through NICE. I just want to talk about the Pathway Optimization Group, which is run by Martin Kaiser and others. And that is looking at some of the drugs that have gone through the generic pathway. So, for example, lenalidomide, are we able to use it in a different way? Pomalidomide, for example, will be potentially available next year. Are we able to use that in a slightly different way? So there are other ways that we are advocating on behalf of the clinical community. So with that, I was going to introduce Sarah Henshaw, who's going to give a nursing update, particularly focusing on daratumumab, lenalidomide, and dexamethasone. And then finally, Catherine is going to give a pharmacy update looking at T-cell engagers.
Thank you, Neil, for that update. Just wait for my slides to come on. So, as Neil said, my name's Sarah Henshaw. I'm lead myeloma clinical nurse specialist at Nottingham University Hospitals. Also, recently, until yesterday, I was chair of the nurse group of the UKMS, but that's now been handed over to Jackie Quinn, who's in the room, CNS from Belfast. So if any of the nurses in the room have got any queries about the UKMS nurse group, then please do contact Jackie. So thinking about the fact that we've recently had the approval of daratumumab, lenalidomide and dexamethasone, I wanted to have a bit of an update and look at the considerations for triplet therapy in older patients. So some of the things that we need to be thinking about and assessing for patients with triplet therapy in particular is patient choice is always the first and foremost and most important thing. Renal impairment we have to take into consideration, the frailty of the patient and their ability to be able to attend hospital for 8 weekly appointments initially, and also the toxicities that are associated and the increased toxicity because of triplet versus doublet therapy. And then the capacity in our clinics, day case and outreach services because of this. So when we're thinking about patient choice, it always comes first. That must be the most important thing. And we must make sure that we offer all options to patients, and we must consider the fact that there are some patients that are severely needle phobic and will prefer oral combinations. And also we need to think about the number of hospital visits, which I'll talk a little bit about shortly. With renal impairment, we also have to consider that with severe renal impairment, a Velcade-based combination may be better in this group of patients. And also we can think about giving pulses of dexamethasone before starting on first-line treatment to see if we can improve the renal function, so we can go ahead with daratumumab, lenalidomide and dexamethasone. And the usual things like hydration and correction of hypercalcemia will also help with this. From the point of view of frailty and the ability to attend hospital, we need to consider the dosing of dexamethasone. So as we know, our patients really struggle with the toxicities of dexamethasone, and particularly the elder group of patients. So it's about thinking about the dose of dexamethasone that you're starting with. Do you have to go in with a big 40 milligram weekly dose, or can you do a 20 milligram weekly dose, or even a 10 milligram weekly dose, dependent on the stage of the disease? Also, when you're in the later lines of therapy, so when you're down to your monthly daratumumab injections, can you actually stop the dexamethasone in the later cycles and use montelukast as a pre-med, etc.? From the point of view of managing the schedule, there's the complexity of the treatment. So many nurse specialists are already used to the complexities of patients and making sure that they're taking the pre-meds, having had DVD approved in second line. So using written schedules, dose set boxes, telephone reminders. So our outreach service, when they're going out, they do a telephone call reminder the day before to remind the patients to take their pre-meds an hour before their visit. Administration of pre-meds on day case if all else fails. So there is that group of patients that you can never get them to take the right thing at the right time. So in that case, you have to extend your day case appointment and give the pre-med on day case. And also considering telephone clinic reviews so that the patients aren't having to come backwards and forwards to the hospital, and community delivery of services if available in your area. From a toxicity point of view, so when you move from doublet to triplet therapy, there is the increased risk of thrombocytopenia, anemia, neutropenia and lymphopenia. There's also the VTE risk associated with the combination, infections, injection site reactions, and obviously the long-term side effects of lenalidomide that we're all used to managing now, like bile acid malabsorption, secondary primary malignancies, and bone marrow function being affected. Some of the ways to manage this is mid-cycle reviews, and this can be done in nurse-led clinics. They can be telephone or face-to-face to see how patients are getting on treatment and manage their toxicities. Using effective prophylaxis for the infection risk, so antimicrobial, antiviral, and in some cases where needed, antifungal. And vaccination status, making sure this is up to date with influenza, pneumococcal, and new COVID vaccinations. There's also VTE prophylaxis to consider, and obviously a lot of us previously been using low molecular weight heparins, but with this more of a shift to using the DOACs for the oral combinations for the patients. And rotating injection sites is helpful with injection site reactions, and monitoring the reaction, and treat where necessary with certain creams and things if they're getting too severe. From the point of view of your anemias and neutropenias, the use of GCSF, erythropoietin is quite important. And we need to make sure we're monitoring the bowels on these patients, and if they are getting excessive diarrhea that's not being controlled, we need to consider treatment of bile acid malabsorption. You can do CCAT scans to confirm that it's bile acid malabsorption, but I know in our centre a lot of the time we prescribe cholestyramine to see if it helps, and 9 times out of 10 it does. And obviously education of the patients. All the patients need to be able to understand the importance of monitoring for infections. From a day case capacity point of view, we need to make sure we're streamlining day case attendances and use of chairs. So there is a chance when you've got a day 1 daratumumab, if you've got space in your day case department, does the patient have to sit in the actual treatment chair for 4 hours, or can they move somewhere else? Use of oral pre-meds so that patients can take it before they come for their appointments. Self-administration of bortezomib that a lot of centres are doing now to take that treatment out of the day case area. Community delivery services, so there's outreach services out there, chemo buses, using local health centres for delivery of treatments. And one thing that I found quite interesting when I was looking at this is when you look at the number of treatment visits over a 12-month period for these patients, in an older group of patients, where we was using VMP weekly before, so a VMP weekly over a 12-month period is 36 visits, because that treatment stays weekly all the way through, compared to daratumumab, lenalidomide and dexamethasone, where the visits over 12 months is actually only 22, because it eventually goes down to once-a-month visits. And lenalidomide and dexamethasone obviously will be less, because it's an oral treatment and patients can be kept at home, and in theory they would only need their 12 visits for their Zometa. Thank you. I'm now going to hand over to Catherine, who's going to give the pharmacy update.
Thanks, Sarah. Good morning, everybody. So I'm going to give a brief update on the use of T-cell engagers. Neil's already said that some of the bispecifics will be approved by NICE early next year. I'm going to talk briefly about some of the practicalities of delivery and some of the expected side effects and management. So firstly, these agents all require step-up dosing to reduce the risk of CRS. From certainly my experience of using agents in the compassionate use programme, it has been mandated that these patients are hospitalised for the initial and step-up doses. There is the potential in the future to deliver these step-up doses in an ambulatory care or day case setting, but that clearly requires risk assessing your patients and making sure you've selected the right patients, and having the proper infrastructure to manage it so that patients with grade 1 toxicity can be hospitalised as necessary. I'll talk about infection in a later slide, but it's very important to ensure you've got appropriate antiviral prophylaxis for zoster and herpes and simplex, and also PCP. When these drugs are started, you get an initial cytokine release, which can interfere with CYP450 enzymes, increasing the exposure to CYP substrates. So that would include things like warfarin, SSRIs, cyclosporin. So it's important to be aware of those. And importantly for teclistamab and talquetamab, the step-up dosing is using a different strength vial to the standard vial. So there's a risk of misselection, dose errors, and it's important that you've got a risk strategy for managing that. If pharmacy are making up your doses, you need to think about the short expiry and actually how that impacts on the patient pathway. So prior to starting therapy, it's really important to rule out infection. So baseline screening should include hepatitis B and wider viral screening. Important to check your immunoglobulin levels at baseline and throughout treatment. You want to ensure you wouldn't want to start if somebody's got active infection, because it will exacerbate the CRS. CRS occurs in quite a high proportion of patients, so up to about 70%, but it is generally grade 1 and grade 2. But again, important to look at vital signs, both at initiating treatment and throughout the step-up doses. ICANS can be monitored for using the ICE score, and there's a table at the bottom of the slide with an example of this, and that should be done at baseline and twice a day during the initiation and step-up doses. You can, there may be fetal harm from bispecifics, so it's important to verify pregnancy status before starting treatment, and women of childbearing potential should be advised to use effective contraception during and for 3 to 4 months post. Pre-medication is essential before initial and step-up doses, and obviously if you need to repeat step-up doses or a patient experiences CRS, you may need to give more frequent pre-medication. You'll see that there isn't a huge difference between the 3 agents in terms of dosing, and they all need to be given at least an hour before, and importantly, you should be given corticosteroid and antihistamine and paracetamol. So moving on to toxicities, most CRS will occur during the step-up schedule. The mainstay of management is tocilizumab and steroids. Tocilizumab should be considered with grade 1 CRS, and corticosteroids tend to be limited to grade 2 onwards to minimise the negative impacts on efficacy. Obviously, you would treat as per neutropenic sepsis and ensure that any fever or any sign of infection had resolved before continuing with your step-up dosing. ICANS is rare, so approximately 3% of patients, and there were no grade 3 to 4 reactions with teclistamab in MajesTIC-1, which was similar to elranatamab. Corticosteroids are the mainstay of treatment, and with grade 1 you would consider prophylaxis, seizure prophylaxis with Keppra. Again, you could consider tocilizumab, particularly if there's concurrent CRS. Grade 3 neutropenia is common, particularly in the early cycles, and consider GCSF. Think about GCSF use, though, during that initial phase because of the potential to exacerbate CRS. And finally, need to think about the unusual toxicities associated with GPRC5D. So that's expressed on salivary, skin and nails, and so you will see toxicities related to those where those antigens are. Taste disturbance can occur in up to 60% of patients, and you may see mucositis, dry mouth, dry skin, rashes. So just moving on to sort of longer term infections, in a recent meta-analysis of 16 trials which involved over 1,600 patients, the prevalence of all grade infection was 56%, with grade 3 or 4 in 24% of patients. Perhaps not surprising, given that these patients are heavily pre-treated. They will have had three or more lines of therapy and often more, so they have a fair degree of immune dysregulation from their treatment, but also their underlying disease. Grade 3 neutropenia and lymphopenia are common, and T-cell exhaustion may contribute to the atypical infections that we see with bispecifics, so PCP, CMV, Aspergillus. And given that BCMA and GPRC5 are both expressed on plasma cells, it's not surprising that we see high rates of hypergammaglobulinemia, which can occur in up to 75% of patients, and there is a recommendation to use IVIG and SCIG as per DH. These are given as repeated infusions, so there is prolonged toxicity. As Sarah's already alluded to, it's important to ensure appropriate vaccination. As we start to use these agents earlier, really important to check post-transplant vaccinations have been given, and encourage patients to have flu, COVID themselves, but also make sure that their relatives do as well. And important to remember that when we start to use bispecifics in combination with other agents like daratumumab, we'll see high rates of infection and may need to think about targeted prophylaxis for them. So finally, teclistamab is licensed but not reimbursed. Talquetamab, elranatamab free of charge programs have now closed, unfortunately. If you are using a bispecific as part of a free of charge scheme, remember that the tocilizumab is not commissioned by NHS England, and equally the activity associated with that admission is not funded by NHS England. So I will leave it there. If I could just give a quick plug to the UKMS Pharmacy Group Education Day on the 28th of November. If anybody's interested in attending, please grab me. Thank you.
So thank you very much. I think it's we've deliberately kind of kept the slides relatively short so that we've got an opportunity for questions. Was there anybody in the audience or online that wanted to have any comments?
So I'll start off. I've got a question really just in terms of what always happens is we get these unintended consequences when you get an approval through. If you've got like a patient who's in their late 60s, fittish, we might have sort of pushed them towards a transplant in the past. Do you think that kind of calculus is going to change now that you've got a very good non-transplant option? And is there going to be any hard and fast rules on who we're going to take to transplant and who we're not going to take to transplant? I'll start with Neil.
So I think there's no doubt the Maya data is really impressive, and I think I imagine the fitter younger patients we're still going to take to transplant. I think it's your around 70, late 60s, early 70s, with comorbidity, the MEL140, are they, would we go through with transplant for them? And actually from a quality of life point of view, the fact that you're not going to have to go through the stem cell transplant and recovery, and that there's a very impressive DRD data may push you probably not to offer transplant for them. And I think we're going to have those discussions early on because the pathway is going to be defined. And then the final thing is the real world data. So does it really deliver what the Maya study said? Let's hope. I don't know.
Yeah, I personally think from a quality of life point of view that we will be using more DRD in that sort of 65 to 70 age range. And like Neil said, if you've got other comorbidities, it's no longer, I think what will stop happening is that whole, well, let's start them on the intensive pathway and see how they do on Dara-VTD before deciding whether to transplant them. I think it will take that part out of the equation.
Any other questions? I've got one more as well, just in terms of pathways. So we're now probably looking 2-3 years ahead, you're going to get patients progressing on Dara-Len. So at the moment, we're sort of giving second-line Len or second-line DVD, neither of which will be appropriate. So none of these things, all these approvals get done in isolation. There isn't like a coherent pathway. What are we going to be doing with those patients in a couple of years' time? You've got somebody who's now sort of 73 or 74 years old, was relatively fit, but you didn't transplant them. They're now progressed on Dara-Len. Where do we go then? Catherine?
I think it's really, really difficult with the way the pathways are, and I think the commissioning changes, as you say, are not joined up, so you actually look, as one new approval comes in, there's actually a real need to then look at how all the blue ticks are worded to enable drugs to be used, but it is going to be challenging. So that's not really a proper answer. But
yeah. So I think clearly that patient hasn't had a PI, so you would want to give them some kind of proteasome inhibitor. I think one of the advocacy things that I think we need to do is to let, or to engage with NICE to let them know that it's actually not necessarily lines of treatment that's important, but it's actually exposure and refractoriness to IMiD, PI 38, and that clearly that means that we will be wanting to use treatment earlier on rather than necessarily be fixed and be stuck at third line because there's nothing available and coming up with an bridge to get to fourth line. That's not really good clinical medicine. And actually, we need to think about a different way of approaching this.
Any other questions from the floor? Otherwise, I'd like to thank all the speakers for giving us an update on what's happening in the clinical world. Thanks very much. Okay, so I'm Jonathan Siv. I'm a haematology consultant at UCLH. I'm going to be chairing this first morning session, which is going to be on myeloma, bone and spinal disease. So we've got a crack panel of 4 speakers from different specialities. If they could all come up, actually, so just so I can introduce you at the beginning. So we've got, speaking on from the haematology side, we've got Dr. Andy Chantry from Sheffield and Stella Bocock from King's. We've also got, I hope somewhere, Mr. Parag Sayal, a spinal surgeon from UCLH and Queen Square Hospital. And finally, we've got Dr. Katie Spencer, who's an academic clinical oncologist from the University of Leeds. So I'm not sure if the spinal surgeon has arrived yet. But what we'll do is we're going to start off with a brief overview of these sort of 3 approaches to managing spinal disease, or medical, surgical, radiotherapy. And then we've got some case studies which are sort of adapted from real cases that we've seen in our MDT at UCLH. And hopefully, if you haven't done it already, you should have had the information about the voting app. So we're trialing case study voting today for the first time, which will either be great or a disaster. So there will be voting after the case studies. So if you can get that, make sure you've got that set up on your phones or laptops, and then we'll use that to discuss the cases. And we're going to do the talks and then have the discussion of all the cases at the end rather than doing them after each talk. So we're going to start off with Andy Chantry. Thanks very much.
Okay, well, good morning, everybody. So, unfortunately, these images are all too familiar to us still in 2023. Manifestations of myeloma bone disease, which is a disruption of bone remodeling. You have too many osteoclasts driven by osteoclast activating factors, and too few osteoblasts driven by osteoblast inhibitory factors that are secreted by the plasma cells and other components from the bone marrow. So we see terrible spinal disease, long bone fractures, the classic pepper pot skull, and 5% of patients still present with spinal cord compression. So almost 80% of patients have manifestations of myeloma bone disease if you study their imaging hard enough, and up to 90%, pretty much all patients develop lytic lesions as the disease converges. So sites commonly affected are the spine, 65%. These are normal ribs, and these are the ribs of a patient affected with myeloma with an incidence of 45%. In the skull, 40%, the shoulders and the proximal humeri, 40%, and the central MRI image, I think, it tells the complete picture, because it's not just what's happening to the bones, it's the replacement of bone marrow by sort of plasma cell, convergent plasma cells that is causing all the problems, really. 30% in the pelvis and 25% in the long bones. So the consequences of this really need a bit of thinking about, and it's great to hear about focus on holistic measures, but the pain that's associated with bone disease, the decreased quality of life, the inability to work, the economic consequences of that, the increased hospital visits really place a huge burden of morbidity on our patients. So really we should be doing more. I'm just going to spend a few moments just reviewing 3 drugs, Zamita, denosumab, and romosozumab, because it tells us how we got to where we are, and highlights some of the issues. So back to the myeloma 9 trial. This was the trial that showed that Zamita was superior to clodronate. That was criticised because in other countries they use pamidronate as their alternative. But it did demonstrate a reduction in myeloma-related skeletal events, 27% versus 35%. The striking thing, which is still one of the key findings from this trial, was that there was a survival advantage with patients on zoledronic acid. And this translated to something that was really quite significant and had a profound influence on our practice. And it really nailed the practice of monthly Zamita for 2 months. So it was for 2 years rather. So it was particularly in the early phases, the first few months of administration, where these graphs began to separate. So the survival advantage of Zamita, there were caveats. This is a long time ago now, so this was the sort of early 2000s. So other nations did pick us up on the fact that we were comparing Zamita with clodronate rather than pamidronate. It was unclear whether patients without bone disease at presentation did better or not, and most of the survival benefit appeared to be early. So that's influenced our practice by the kind of the thought that really monthly Zamita, even though the half-life of Zamita is more like 12 months, was the way to go. And we've pretty much been doing that ever since. So the median duration of treatment with Zamita was 12 months, given most benefit was early. And we've tended to push this out to 24 months now. It started a big debate in the scientific community about what the potential anti-tumor mechanisms of zoledronic acid were. And Herbie Fleisch, who's a big name in myeloma bone disease, had this concept that it was just a mechanical phenomenon, really, to do with the preservation of bony barriers preventing spread. There was the seed and soil concept, which was more about the reduction of myeloma burden and amelioration of osteoclast activity led to a less favorable environment for the myeloma cells to flourish. There was some idea that there was disruption of cell adhesion to mineralized surfaces. And then there was the debate about whether there was any direct effects of Zamita on plasma cells, pro-apoptotic, or the mevalonate pathway was implicated. And there was this division made between the hydrogen-containing bisphosphonates and the non-hydrogen, nitrogen-containing bisphosphonates. Some people thought they had anti-angiogenic effects, and Peter Crouch had demonstrated in murine models that there was some anti-angiogenic effects of zoledronic acid. There was even the concept of enhanced gamma-delta T-cell mediated immunosurveillance playing a role in survival. Potential synergies with chemotherapies have been suggested as well, particularly in breast cancer, but there was also some thought about whether this was applicable to myeloma. So this really led us to this idea of monthly Zamita. And the practice at the moment is not strongly evidence-based. It still derives across the country from the ASCO consensus statement in 2018, and that was that we would give 4 milligrams of zoledronic acid monthly for 24. This was at disease presentation, and then at relapse, we would start again. And the concept of giving monthly for 6 months and then reviewing and considering pushing out the dose interval was introduced. And there have been some studies that have suggested that this is equivalent. But I think for most of us, we have this feeling that monthly Zamita for years and years and years is a bad thing. Obviously, there's the side effects, osteonecrosis of the jaw and atypical femoral fractures. And if you think biologically, the concept of completely switching off osteoclast activity is not good for the bone remodeling that we are really trying to encourage. So are there any alternatives? Well, before I say that, I just need to give a shout out for this survey that we are doing to try and tighten up on current UK practice, the administration of zoledronic acid. So there is a UKMRI myeloma bone disease working group, and Stella and myself are on it. It's chaired by Sacha Rupa. She recently put this survey out about UK practice for Zamita. So most of the clinicians here will have received this. If you haven't filled it in, we'd be hugely grateful if you could fill it in, because it tells us where we're at, and it gives us a foundation to move towards a more evidence-based set of recommendations. And we are in the process of putting together a position statement for BSH to tie everything together, pharmacological approaches, non-pharmacological approaches that we're about to hear about. Are there alternatives to Zamita in terms of anti-resorptive drugs? Well, denosumab is the key one, and that has a number of advantages. It's a fully humanized monoclonal antibody against rank ligand, which is one of the key osteoclast driving factors. It's got certain advantages over Zamita. It's short-acting. Now, if you're trying to avoid the idea where Zamita is completely rendering bone inert, a short-acting anti-resorptive is very advantageous. And in combination with anabolics, it's showing great promise, but I'm jumping ahead a bit there. It does have some similarities, similar incidence of osteonecrosis of the jaw. There is a problem with hypercalcemia that requires close monitoring. But you can give it to patients with renal toxicity, and many of our myeloma patients are in that category, so it has that advantage. Just a show of hands, who is able to give myeloma patients denosumab? Kerry, well done. So very few of us really, but if you could give it, who would give it? Yeah, so it's quite a compelling, yeah. And this study, the 482 study, was I see John's in the audience here, so John was heavily involved with this study, was a key comparison between zoledronic acid and denosumab. And it reached its main objective of showing non-inferiority. So the time to first skeletal-related event, which is a very hardcore endpoint, was similar. And the overall survival was also similar, because they were also looking to see whether, in the same way that the myeloma 9 trial showed a Zamita survival advantage, whether that was the case with denosumab. And they looked at overall survival and progression-free survival and didn't find much apart from certain subsets. So it proved non-inferiority. And when added to anti-myeloma therapy, denosumab improved progression-free survival versus zoledronic acid, and also in a cohort of patients prepping for autograft, there was a hint of a survival advantage. So it kind of reignited that debate as to what was happening. So I'm going to switch tack now, conscious of time, to the other side of the equation, anabolic agents. Now, it used to be said that myeloma bone lesions didn't heal, but there's increasing evidence that they do heal and they can heal. And so the rationale for anabolic agents like recombinant parathyroid hormone, which unfortunately has been associated with some secondary malignancies. And this drug, romosozumab. So romosozumab is a humanized monoclonal antibody, and it inhibits sclerostin, which is an inhibitor of the Wnt pathway, which is one of the key drivers of osteoblast development. So romosozumab has been licensed in osteoporosis. Now that's a blessing and a curse. It's out there, but currently the companies are not keen on going into a cancer environment. So we are in the process, and my research reg, Becky, who I think is with us, is in the process of designing a trial that would be applicable to myeloma. This is just a summary slide that paves the way for the rationale for combined anti-resorptive anabolic therapy. So you can see the x-axis is lumbar spine, bone mineral density, and then hip bone mineral density is on the y-axis. And the single agents, alendronate and Zometa, showed some advantage. Denosumab, similar advantage, particularly in lumbar spine, and then teriparatide, recombinant PTH. But it was really when you got onto the combined approaches that you were seeing much more substantial increases in bone mineral density, both in the hip and the spine. And the ideal, if you like, combination might well be romosozumab and denosumab. Now, there is an issue here about sequencing, and the evidence from osteoporosis tells us that the best effects and the most sustained effects and effects that don't drop off and are quickly reversed come with sequenced approach. So the sequenced approach recommends that you have a year of anabolic therapy followed by a year of anti-resorptive therapy. And this is the model that has been shown to be the most powerful comparison, most powerful agent. So we have been working with Chris and the CTRU in Leeds, myself and Becky Andrews, to look at what a trial in myeloma might look like. So our comparator, our control arm would be Zometa, because it's very difficult to immediately deviate from something that we've been doing for the best part of 20 years. But in our comparator arm, we would look at the sequenced approach, romosozumab, followed by Zometa again monthly, and then we'd stop at 24 months. The original study participants would be everybody, all comers with myeloma, essentially. So the endpoints is a problem. The original bisphosphonate trials were done on thousands of patients over many, many years, and the hard endpoints were skeletal-related events. To really gather that data, you would need a similarly huge trial going for many, many years. So we've chosen bone mineral density as a primary endpoint, and we've looked at a kind of suite of measures, including secondary endpoints, patient-related outcome measures, biomarkers, CTX-P1MP, and certain exploratory endpoints as well, including certain imaging modalities, MRI, DEXA scan, where we can get it. Now, to do something as thorough as this would cost a huge amount of money. So we are negotiating with UCB about an investigator-initiated trial, and this would be the dream case scenario if we got it. And we're working through UKMRA to work that up. So proposed study procedures, a bit small on my slide, so whole body MRI, DEXA scanning, or CT, bone markers, and patient-reported outcome measures to give a complete picture. So that's this is my last slide, and it's going back to the title, really. What more should we be doing for myeloma bone disease? Well, I have spoken about pharmacological aspects, and Stella and Parag are going to be talking about other issues in KT radiotherapy. So we should be thinking about a cassette of measures that adopts a holistic approach to the treatment of myeloma bone disease. So in the bone group, we're preparing this position statement. This is by its very nature holistic, multidisciplinary, and we should be looking at pharmacological interventions, and we should also be looking at entry into clinical trials. But the other aspects, orthopedic interventions, spinal bracing, radiotherapy, and analgesia and physiotherapy are key elements. And it's only when we begin to regard this as a holistic package of measures for this really horrible aspect of the disease that we all work on that will begin to sort of alleviate a substantially larger proportion of the morbidity. So that's a few opening comments to pave the way for others. And as I understand it, I stop now and we take questions afterwards. Yeah.
Thanks very much, Andy.
Okay.
Someone's doing it for me. Sorry, is someone doing it for me? There's something moving around. Someone else is doing it. Yeah. Okay. Thank you. No, it isn't. No. Task. No. Someone else is doing it for me. Yep. Okay. Okay. Thank you. So thank you for asking me to come and talk about some of the practical aspects of managing myeloma bone disease. So when patients present, first of all, we know that bone disease is a very significant problem to our patients. What we did discover when we looked at presenting symptoms in patients in the TEAM trial was that patients don't come in saying, I've got bone pain. Virtually no patient says I've got bone pain. That's a healthcare construct. Patients come in with pain. They've got back pain or they've got pain in other sites. So they present often with pain in the ribs, just chest pain, abdominal pain, sometimes generalized pain. 8% of people just present with aching and generalized pain. That's important to know when you're monitoring your MGUS patients and your smoldering myeloma patients, that any pain is possibly a signal. When patients come to the clinic, what are their priorities? Well, the first priority is that their disease should be controlled. But then, if they're reassured, the next thing is managing their toxicities, and then they want help with managing their disabilities and their pain. And that's an area we're not very good at because we don't really know what to do. We don't understand it very well. The biggest disability to patients is spinal disease, predominantly due to irreversible damage due to vertebral compression fractures. It's helpful to think of bone disease as occurring in two phases. When the myeloma, underlying myeloma disease is active, the bone disease is active as well, and there's an active disease at that stage. The bones are soft, there's more risk of fracture, and that tends to occur around presentation and around relapse. Then there occurs a more chronic stable phase when the patient is living with pain and disabilities, but they haven't actually often got pain from the actual bones. It's more from the fact that their spine may have changed shape and that their center of gravity has changed, so they're getting muscle fatigue. So I'll talk a bit more about that. The background to these two phases of bone disease is really from all the trials where they've looked at skeletal-related events. Now, this one, I'm using the myeloma 9 trial as an example. And you can see that here, that first of all, this shows clearly the time against the number of skeletal-related events. And these are patients who entered the trial, started treatment, and then these are new skeletal-related events that occurred after they were diagnosed and entered the trial. And you can see that in this first 3 months, that there are a lot of skeletal-related events. So this is the acute phase, and there's a lot happening then. That's the time when we should be really active. And then things begin to settle, the disease comes under control, and the bone begins to harden. There is a bit of a bone regrowth, but it's not normal bone, but nevertheless the bones are hardening and the risk of fracture falls. So it's quite useful, actually, to think that some of these patients with very extensive disease have skeletal failure. The difficulty is that we can't actually measure it easily because we don't have something like a serum creatinine. If they're hypercalcemic, then they probably have a degree of skeletal failure. But there are research markers, but not available to us in the clinic. But patients tell us with their pain, although that can be a bit deceptive because they can just have one compression fracture that's extremely painful, but maybe not very extensive disease, and they are at high risk of further fractures. But what happens with these patients is that the ones who've got a degree of skeletal failure is that they come back to us in the clinic later on, and you can see that their spine has changed shape. So they're not able to resist the normal forces of gravity when they've got these soft bones and acute disease. So what can we do for our patients? We can optimize the management of myeloma bone disease, and Andy's talked about the drugs. It's really important to give the first doses a metre early. And unless my patient's got terrible teeth, I try and get the first dose in within the first month, because we know that survival benefit comes in early, as well as, so we should be. And we know from that graph that there's a lot happening in the first 3 months. The risk of fracture is high, and we need to counsel the patients about being careful. And then we're going to have talks about vertebral augmentation, bracing, and radiotherapy, so I will cover a bit about bracing. But as haematologists, we need to understand the spine and the cause of their pain. They may be lucky enough to see a spinal surgeon, but they may see the spinal surgeon once or twice. They see us month in, month out, and we need to take an interest in their spine. We need to look at the images, understand what's happening, and counsel them a bit about their types of pain and and help them understand their pain. And then I can't emphasize enough how important it is for us to encourage the patients, once they get into a more chronic phase, to increase their exercise gradually and carefully, and to become more active and not to be too scared about it. So what are the causes of pain in people who have myeloma spinal disease? Well, in the acute phase, there's the acute tumour expansion, or there can be acute vertebral compression fractures. And then in the later phase, it's very different. They don't tend to get pain when they're at rest, but they get pain because the centre of gravity has changed, and I'll just go through that. In the acute phase, they get pain from the tumour expansion. Sometimes it's pressing on other structures, particularly if there's soft tissue expansion as well, and plasmacytomas. There's nerve ending disruption, and it's pulling the nerve endings, but also there's new nerve sprouting. And there is also sometimes regression and death in these nerves, and that also causes pain. There's also an acutely inflammatory microenvironment around the tumour, and that causes pain as well. The management of that is to manage the tumour and to control it. And we know that as soon as we give anti-myeloma treatment in newly diagnosed patients, often their pain goes away quite quickly. Then there's the pain of acute vertebral compression fractures. And that can often be acute, abrupt in onset, brought on by coughing or sudden movements. It can sometimes be asymptomatic, though. The thing that's important to recognise is that once they begin to get one vertebral compression fracture, they're at a higher risk of getting another one because they're beginning to tip forward and the centre of gravity is moving forward. And that is managed by analgesia and to some extent trying to reduce the amount of micro movement. That's what the patients tend to do themselves a little bit. They don't move when they've got an acute vertebral compression fracture. But then there's the later pain, once the bones harden up a bit, and the pain of the acute tumour tends to go, but then they get a different kind of pain. This is a normal spine, where you have the normal thoracic kyphosis, and then you have the lumbar lordosis. And it's nicely balanced with a sort of centre of gravity running from C7 through to the sacrum. What tends to happen with our patients is mostly their centre of gravity shifts forward, and you can see immediately that the back muscles and the ligaments are going to have to work extra hard to try and stop that patient tipping forward when they stand up. And so you will find, if you speak to patients, that they have a different kind of pain. They don't tend to have pain at rest, but once they're standing, they say after about 5 minutes, I begin to get this terrible aching pain. And that's often the pain of back muscle fatigue. And you can see this poor chap, his centre of gravity has moved very far forward. And his back muscles are going to be working incredibly hard to stop him falling forward. And sometimes they bend their knees in order to do that. Now, the other, I'll just cover that in a moment. Analgesia, chronic analgesia, may not be helpful for these patients. And sometimes, it's not true for everyone, but it's important to consider reducing the long-term opiates and encouraging them to stop long-acting opiates at this stage. But some of these patients it's quite useful for them to use short-acting opiates when they know they're going to be active. So but they may not need continuous modified release morphine. The other thing I just wanted to say was that in the spine, it's very important to recognise that as a patient walks in, that you can't judge the amount of pain they've got from what they look like in their clothes. And I mean, I'm not a spinal surgeon, but this is what I understand, is that they tolerate a degree of kyphosis in the thoracic region, and that much better than they do around the thoracolumbar junction. This junctional area is very important, and that's the most important to change their centre of gravity. And yet you don't see that so much when they walk in. So they look really bad if they've got this. But actually, what's worse in terms of disability is this area. So can we prevent kyphosis? Well, Sean Malloy at Stanmore has pioneered the use of spinal bracing for 12 weeks in newly diagnosed myeloma patients. They do this to reduce the risk of kyphosis and possibly reduce acute pain. And they think it works. A few sites are beginning to brace, but they are awkward, they're expensive, they can be uncomfortable for some patients, and we really don't know whether they work. It's easy to think that something works because you're doing something rather than doing nothing, but we really don't know. So we're working to set up a phase 3 randomized controlled trial of bracing for 12 weeks or not in newly diagnosed myeloma patients with spinal disease. We are hoping to get funding for it. The question is, does bracing reduce pain and subsequent hyperkyphosis? Funding, we don't know. We'll know at the end of the month. But if we don't get the funding from the NIHR, we still need to find a way of doing this trial. Please support it if it becomes available next year. It's such an important trial, and it could make a big difference to patients' quality of life. So just to finish, as survival improves, we really need to do everything we can to maintain a functional and painless musculoskeletal system for our patients. Thank you.
Thank you very much, Stella and Andy, for a biological and a sort of clinical approach to how we as medics probably ought to be better at managing spinal disease in our clinic rather than just prescribing more opiates. We're going to move on to other approaches now. So we're delighted to have Dr. Katie Spencer, who's an academic clinical oncologist at Leeds, the University of Leeds, and she's going to be talking about what's the role of radiotherapy in myeloma spine disease. Thanks very much for coming.
Okay. Thank you very much for the invitation. So I'm going to speak about radiotherapy, and I'm feeling a little bit like the black sheep in the room, so bear with me if I've spelt the drugs wrong. I know one of them is already. So just going to go through a little bit of the process, principles and indications for radiotherapy, and then very briefly, potential in the future. So what does radiotherapy involve? You guys probably already have a reasonable idea of this. This is a patient having a radiotherapy SIM scan. They're having treatment to their cervical spine, so they've got a mask on. It's holding their shoulders and their head nice and still, so we know we're treating the right bit. Once they've had their SIM scan, we will plan the radiotherapy and decide how we're going to deliver it. And by and large, the image on the left is how we're going to do that, because we deliver very simple treatments a lot of the time, which we get done very, very quickly and get the patient through and treated to get the benefit of their treatment. But on the right-hand side, we see the treatments that we deliver sometimes maybe when we're giving higher doses, much more conformal, and minimize the side effects by reducing the dose to surrounding organs. And then finally, once we've done that, obviously the patient comes back to have their treatment delivered, and this is a linear accelerator. You can see there's knee blocks as a headrest, so if the patient's having treatment to their thoracic or lumbar spine, they'll have those in place for comfort, and the machine moves around them to deliver the treatment. So I knew this would happen. There's a graph in behind there, which shows the impact of fractionation. So why do we fractionate? You'll hear us talk about 8 gray in a single fraction, 30 gray in 10 fractions. What we're trying to do when we fractionate is we deliver the total dose spread out over multiple small fractions. And so what we can see in this graph is the impact of fractionation on both normal tissue and below on the tumour tissue. And we can see that as we fractionate, the cell survival drops more in the tumour tissue than it does in the normal tissue. And so we open up a therapeutic window. And that is particularly marked in late responding tissues. So things like spinal cord, if we fractionate, we reduce late toxicity. We can deliver a higher dose by spreading it out over time. We don't have that much of an impact upon the acute toxicity because that's more to do with the total dose that's delivered. So when we're thinking about fractionation, the things that we're really thinking about in terms of should we are what's the expected prognosis of the patient? Are we really worried about late toxicity, or do we just want something pragmatic that's going to get the patient treated quickly with minimum amount of burden? We're worried about organs at risk. If we're treating the spine, there's always a concern about the amount of dose that we can deliver. We're thinking about the incremental gain. How much extra are we going to get by fractionating treatment? And then finally, what previous treatment have they had? Have they already received significant doses that are going to cause us problems? So in terms of those contraindications, I said, what's the previous dose? Well, previous radiotherapy, we can give up to 50 gray in 2 gray per fraction to the spinal cord. So that's pretty sizable. But if we give that in smaller, big doses, that actually adds up to more. So we have this concept called the equivalent dose in 2 gray per fraction. And what we need to do is we need to calculate, well, what is the impact of a larger fraction? And it may mean that we need to review previous plans. Patients who've maybe had radiotherapy for another indication may well have had exposure to organs at risk from that other indication. So it's not just about their myeloma, it may be about any other malignancy that they've had treated as well. We can't treat people if they're not able to lie still, and we've seen that mask for patients for the head and neck region, but this is relevant across the whole body. If the patient has so much pain they're unable to lie still, it's going to be very difficult to treat them, and so we need to get their pain reasonably controlled before we can give radiotherapy. If they're confused, they're not going to be able to lie still as well. And similarly, if they have problems with hypoxia and lying flat, then they're not going to be able to tolerate treatment. And then relative contraindications, really end of life, but it's only relative because we know how poor we all are at predicting it. And we also know actually that patients with myeloma may well respond quite quickly. And so that very much is a relative contraindication. And similarly, whether or not a patient can consent, as you know, we can go ahead if they're able to manage the treatment and comply. So in terms of indications, we've got pain for vertebral metastases. We've got pain from nerve root compression. So you've got more soft tissue disease there, compressing the exiting nerve roots and causing neuropathic pain. And then malignant spinal cord compression. I'm going to talk about pain and cord compression a little bit. So I've got an example case here. It's a 54-year-old man with known myeloma. He's currently on carfilzomib, forgive the spelling, lenalidomide and dexamethasone, and that's after relapse 1 year following an autograft. He's restarted Zamita, and he presents with worsening constant mid-thoracic back pain in the clinic about cycle 8. His MRI doesn't show any evidence of MSCC, but he does have T9 vertebral disease and significant other areas of disease as well, but the T9 fits with this mid-thoracic back pain, and his paraprotein is stable. So what are we going to offer this gentleman? Well, if we look at the MRI scan, we can see that there is vertebral disease, but the vertebral body appears intact. There's no compression there at the moment. So we could offer palliative radiotherapy. We could consider surgery, but actually the vertebral body appears intact and the pain that's described suggests that this is constant, it's not instability pain. So palliative radiotherapy could be simple or 3D conformal, as I said earlier. We're going to think about the dose, and actually this gentleman's on treatment at the moment. We may not want to change the systemic treatment, and so actually giving a single fraction of radiotherapy feels like a very good option. We don't have to interfere with the delivery of systemic therapy. We just fit the radiotherapy in around that. Historically, we've always given a single 8 gray, and that's what the literature supports from a solid organ setting and to a degree in myeloma. But actually in myeloma, we may be able to get away with an even lower dose for these patients, which is quite appealing when we know we may well have to come back on multiple occasions in future. So there's a 20% reirradiation rate with a 4 gray fraction, but actually that's 80% of patients for whom we don't need to reirradiate the same site. So there's certainly advantages there. And obviously we could fractionate, but actually in this context, all of the literature would suggest that a single 8 is just as good as a longer course of treatment for managing pain. So in terms of considerations, well, we need to think about the extent of the symptoms. Are these symptoms that are controlled with simple analgesia, or are we starting to need more analgesia? Is this instability, pain, or vertebral collapse? In which case, I think I'll be referring on to my colleague who'll be speaking next to think about how best to manage those really, because no amount of radiotherapy is going to reinflate a vertebral body once it's collapsed. We do need to think about the systemic therapy. Where are we up to? How are we going to impact on that with radiotherapy? Organs at risk, the prognosis, and also in the long bone setting, whether there's already completed pathological fracture or impending pathological fracture. So overall outcomes with palliative radiotherapy are really excellent in the myeloma setting. So 85% response rate, of which about 30% of patients will get a complete response. And those can be very prolonged, so those can be sustained for a year or more. And we do see recalcification in a proportion of lesions as well. So who does best? Well, people with instability don't do best. So we know that for patients who've got a higher SIN score, they have a lower rate of complete response. It doesn't appear to impact on the overall response rate, so it seems quite likely that we're impacting to a degree on the myeloma, but not so much on any vertebral collapse. But there are issues with this, it's observational data. The little stars on here are to say that there's a lot of health warnings with a lot of these data because they're based on observational cohorts, and it's very difficult to unpick sometimes what's going on. Soft tissue expansion predicts higher response rates in the solid organ setting, and we often see that in myeloma. We see excellent responses. So I think it's fair to say that soft tissue expansion is probably something that radiotherapy will manage well. Steroids are associated with a lower response rate, and that probably reflects that the patient's already on a significant amount of treatment and has disease that's at a later stage. There's no association with any baseline inflammatory markers that we know of. But higher radiotherapy doses can be associated with higher response rates in observational data. This conflicts with the solid organ data in randomized controlled trials, so it's a little bit difficult really to interpret because those patients who receive a fractionated course are often the ones with better prognosis, better outlook, maybe better performance status, and actually they're probably always going to do better than the patients who receive a single fraction. So if we move on from the vertebral METs to spinal cord compression, we've got another patient here, 63-year-old man with worsening back pain over the last 2 months. He's had a recent diagnosis of myeloma but not yet started treatment and has new onset of weakness over the last 3 weeks. His bone marrow shows 60% plasma cells. He's got bad cytogenetics. And his MRI shows malignant spinal cord compression C3 through 6 with a big paraspinal mass that you can see on the axial image there. There's also widespread bony disease elsewhere. He's got renal impairment and he's a bit anemic with an IgG paraprotein of 45 grams per litre. So this gentleman's got nasty myeloma and has not yet received any treatment. He started on dexamethasone and analgesia, but how are we going to manage his MSCC? So we know we've got surgical options for managing MSCC, but also radiotherapy, and we know that actually radiotherapy works very well in myeloma, particularly with soft tissue disease. But what are we talking about when we think about malignant spinal cord compression? Well, the slides that you've just seen, those images, are very much neurological impairment. We've got a gentleman who's off it, who's got reduced mobility, he's got neurological impairment and soft tissue. So that's sort of severe end of MSCC. But the MSCC is often mixed up together. There's radiological MSCC only. Maybe the patient's had a staging MRI at the beginning and they found to have MSCC, but they're completely asymptomatic. Maybe they've got pain at a relevant site, or indeed radicular pain, and then finally neurological impairment. So MSCC isn't all one bag, and we do need to think about, well, actually, are we thinking about compression fractures? Are we thinking about soft tissue? Is this a nerve root compression from a soft tissue mass? And what's the role for surgery versus radiotherapy? And these things are often combined in studies, and so it becomes a little bit tricky to unpick exactly what's going on. We do see excellent outcomes, though, for patients with neurological MSCC in myeloma. So in contrast to solid organ cancers, we see about 50 to 80% improved functional status following radiotherapy. And that's quite striking in comparison with the solid organ setting. Excellent local control. And there does appear to be a dose-response relationship, so higher doses providing better and more durable responses, although that isn't maintained in the patients who have got a poorer prognosis. So in those patients, it's entirely justified to give a much shorter course of treatment. There is less of a role, arguably, for surgery than there is in the solid organ setting if there is no instability and the vertebral body is intact. We know that surgery improves neurological outcomes for patients with solid organ malignancy and MSCC over radiotherapy alone. But in the hematological setting, actually hematological malignancy predicts improved outcomes and mobility without surgery. So it's reasonable to think that actually we don't necessarily need surgery in the absence of loss of structural integrity. And particularly in patients like the one that we've just been looking at, where there's a real need to get onto some systemic therapy, they've got more extensive disease, radiotherapy feels like a preferable option in order to be able to get good control of their local problems in their neck, whilst also allowing them to proceed with systemic therapy at the earliest opportunity. So I think I've mentioned this already, but the things we're thinking about really in the MDT, we're thinking, has the patient got instability symptoms, vertebral collapse? How quickly do they need to get onto their systemic therapy? And what's their prognosis? And in terms of those indications for surgery, as I said, no amount of radiotherapy is going to reinflate a collapsed vertebral body, and particularly if there are bony fragments in the canal, that is not going to be amenable to radiotherapy at all, and we need surgical intervention to manage that. When we get down to sphincter disturbance, there's probably less importance there because actually that is likely to improve with radiotherapy if it's soft tissue related. And finally, I just wanted to mention, this is from the solid organ setting. There's a recent trial that Erin Gillespie has carried out in the States looking at the use of palliative radiotherapy for asymptomatic but high-risk bone metastases in solid organ disease, and demonstrating in a relatively small randomized phase 2 reduction in skeletal-related events and an improvement in overall survival. And I think this is, if this is demonstrated again in phase 3 data, this is paradigm shifting in the solid organ setting, because we have always said we use radiotherapy in this setting for symptoms. We don't use it for asymptomatic disease. So this is a paradigm change if it is carried on. And I just wonder to what extent we might be able to see that in myeloma, whether there are places where maybe patients have had a very large lesion at baseline, they've responded excellently to systemic therapy. Is there a role for consolidation? And at the moment, we genuinely don't know. So I think that's something that would be interesting in future to think about. So I think in summary, there's a role for radiotherapy alone that is probably greater in the management of spinal disease for myeloma than in solid organ malignancies. A lot of our evidence is extrapolated from the solid organ setting, though, and we really need to think about making sure that we give the right treatment at the right time. Is radiotherapy right? And if there is a loss of structural integrity and particularly instability pain, then really we need to be talking with our surgical colleagues about optimal management in a surgical setting instead. So thank you, and I think we're going to take questions afterwards. Yeah.
So just if anyone's able to bring another chair up to the panel, that'd be quite helpful. That's what we do, musical chairs at the moment. But I'd just like to introduce the final speaker, who's Mr. Parag Sayal, who's a spinal surgeon who works at UCL/Queen Square National Hospital for Neurology and Neurosurgery, to talk about the role of surgery.
So this is not going to be a talk much on blood or metalwork. Partly because maybe I'm not a good surgeon, which clearly is not true. I'm a great surgeon. But mainly because I don't think myeloma is a surgical disease. And I'm glad a lot of people agree. So when I get into a problem, I kind of think, let's quantify the problem first. Being a clinical lead, I need to know what numbers of patients are coming into clinic, what capacity I need. That's not really the case. But anyway, so we encounter spinal myeloma disease referrals 2 or 3 times a week within UCH. And in the context of spinal cord compression. So I'm not just talking about vertebral body involvement. We're talking about proper spinal cord compression. Now, this does not mean spinal cord compression with neurology. And that's really important to differentiate here. And hopefully that'll become clarified. But you can see 60% of patients may have a spinal involvement right at presentation. 70% of patients may have osteolytic lesions at some stage, but more importantly, the same patient can have multiple skeletal-related events over the course of the disease. And then I'm not just talking cord compression here. We need to look at kyphosis, deformity, and pain. Distribution, we know it's largely thoracic, more so in cervical than lumbar, and then multi-site involvement is not uncommon at all. I think this is a really important differentiation here, and I think as surgeons we need to understand this as well. Soft tissue disease versus bony retropulsion. So on the top, you can see there's soft tissue compressing the spinal cord, and that really responds to radiotherapy. Whereas if you've got a lytic lesion in the bone has prolapsed backwards and is compressing the spinal cord, that's where maybe a good surgeon may come into play. But then there are so many scenarios here when a patient presents. You can have a patient with spinal cord compression, which could be soft tissue or bony. You could have a patient with cauda equina compression. Now, cauda equina is much more forgiving. To get a patient with cauda equina compression, everyone rushes because it's a buzzword, but in reality, they hardly ever get motor deficits, even when there is bad compression. So there's a bit of time to play there. And then we talk about stable neurology versus deteriorating neurology, and that's super important. If someone's got sort of mild weakness, but they're actually pretty stable with that mild weakness versus someone who's deteriorating within 24, 48 hours, rapidly going downhill, that's an important differentiation for us. And then there's non-compressive involvement, which is actually a very, very large part of the referral group as well, where they have either pain. And then the most important thing, how do we assess which patient with lytic bone involvement is going to develop kyphosis and develop instability? Is there a way of doing that? Are there any studies to do that? Published literature, if you kind of just look through the evolution, 1990s, it was just all about decompress or fix, just decompress, fix. And then someone decided they didn't have time to do that, so they decided to do some vertebroplasty. And then that's happened in 2000s. And then again in 2010, all the literature kind of goes towards more individualized approach, going really far away from decompression. And also vertebroplasty has been tempered down in many ways. What do we look for? I think the SIN score, everyone talks about this instability score. And I don't try and remember exact numbers. That's for my registrars to do and tell me. But what I try and do is I look at the most bullet points there. I say, what is it that's guiding me towards finding out whether something's unstable? When someone has pain when they move, that's unstable. When they don't have pain, they're walking around and their scan doesn't look that good. Hey, they're probably still stable, even though actually, and then lytic lesions, obviously. So it's all very intuitive, as I tell my registrars. If something has collapsed more than 50%, it's going to be unstable, probably, but something is fully intact, probably not going to be unstable. So trying and remembering these things is just the bullet points there. Location, the junctions, the thoracolumbar junction is a very key area to look at. Traditional spinal surgical scoring system. So again, in the middle of the night, referral comes through for an MSCC. First thing you say to the registrar, hey, what's the Tokuhashi score? Actually, it doesn't really matter in the myeloma. It doesn't tell me much about it. It's not validated for this properly. And actually, if you try and apply these prognostic scoring systems to spinal myeloma disease, it isn't going to give you a good answer. So we need to stay away from that. There are various sort of papers which talk about in myeloma spinal disease, what are the prognostic factors which affect surgery. And again, if you look at this, spinal involvement doesn't really influence overall survival according to some papers, but it's actually the main characteristic is the primary myeloma disease. So we've spoken about prevention, so I'm going to skip through this. But again, this is really important. Prevent. So you don't want to see a surgeon, so just prevent this really as much as you can. This is quite important, very interesting. In 2000s, they did this big study where they looked at the cancer registry as to the trends in vertebroplasty. In the early 2000s, there were multiple vertebroplasties being done. By the end of 2000 or 2010, the numbers had come down. And why is that? And that's partly because the indications were tempered down. Initially, everyone was being offered vertebroplasty, and then subsequently, select few. And we need to understand who those select few are. So what is a vertebroplasty? It's very simple. You hammer a needle into a bone under X-ray guidance and inject some cement. It's easy as that. But then what is kyphoplasty? Well, actually, we want to be a bit more glamorous, so we said, okay, let's put a balloon in there. And what will happen is that balloon will very nicely inflate the body because the body is going to say, okay, balloon, come and re-inflate me. And then you inject cement in there. This is theory. In reality, when you do balloon kyphoplasties, you do not get such good restoration. It is a good concept. We do it, but let's be aware that actually balloon kyphoplasty is not always the answer. Cement will leak out through the bone, that bone is super soft. You put a balloon through it, that bone is going to probably rupture in some way as well. So you have to be very careful. Not saying balloon kyphoplasty is not the answer, but this is what is done in balloon kyphoplasty. There's good evidence for pain improvement, so we don't even have to debate that. So when in multiple myeloma patients, so not in osteoporotic fractures, but myeloma disease patients, there's really good evidence out there that it improves pain scores, it improves disability. So one of the concerns used to be, so I'm going back slightly, if you look at the back wall, so if imagine the cement, if the back wall of the vertebra is defective because of disease, could the cement leak out backwards? That was always a big concern. And there are publications about this actually, that even if the posterior wall is defective, you can actually do kyphoplasty or vertebroplasty if you do it properly in the correctly selected patients. So there was this really good guideline paper that came out, and Sean Molloy, again, we talk about, but it's a very, the entire Stanmore group, where I also work, has done a lot of work on this. And they looked at balloon kyphoplasty and vertebroplasty, and they provided some indications. And again, very intuitive indications. If someone's got pain, instability pain, which hasn't improved for 4 to 6 weeks, you've given them a brace, you've asked them to modify activities, they're suffering, vertebroplasty is not, or kyphoplasty is not a bad option at all. And then you talk about this other relative indications, and that's where the thoracolumbar junction comes into play. If at the thoracolumbar junction you start getting kyphos, you will not regain that no matter how much muscle you use. You can be literally like this, you can stoop backwards to pull your muscles back, and then what starts to happen is your thighs start to hurt really badly. So thoracolumbar junction kyphosis prevention is a good thing to do if you can. So think about that. But kyphoplasty, again, everything has risks. So if the cement leaks out, you can get adjacent level, you can obviously get neurological deficits if it leaks out into the spinal cord area, which is great because I've created another extra surgery for me to do, because that you have to think about these things. And the risk of discitis shouldn't be underestimated. You're injecting cement into somebody who is likely to get some sort of infection. They're much more prone to having infections. So actually, when you do these things, you think about giving antibiotics. If you cement one level, the level above and level below comes under stress. So it's not always the answer, because the other level then can start getting compression fractures. Surgery, there are different things you can do. So I don't think of kyphoplasty or vertebroplasty as a surgery. I think it's a procedure, most commonly done by my radiology colleagues nowadays. We just supervise it. But surgery is decompression, instrumented stabilization, or instrumented stabilization alone. And decompression is pretty much out now. I mean, it's hardly ever indicated. If you look at the literature, again, there was so many reports from 1980s, 1970s, where every myeloma patient was getting a decompression. It's really not needed at all. Surgical papers tend to be very misleading. I love this paper because it says surgical management of spinal fractures, and they say it's surgical management is great. That's what the conclusion is. But actually, if you read through the paper, their complication events were 55%. And 25% had surgical complications. So I didn't get that. How did that happen? I thought the paper said it's a great thing to do surgery. And then you look at this relevance of surgery, and this particular series actually was a bit more circumspect about things. They wanted to have a look at this in a pragmatic way. And again, 55 patients underwent surgery here. The problem with all these surgical papers is they do not describe who underwent surgery for bone retropulsion versus soft tissue disease versus instability. They just club them all together. And that creates a massive amount of uncertainty in the data. But again, in this series as well, they had 8 patients with major complications out of around 56. So that's good. You're getting 15% surgical complication, major complication rate. So why is surgery not an ideal option? Well, the risk of surgical site infection should not be underestimated. It can be as much as 10% after surgery in myelomas. Admittedly, my rate is less than 0%, but that's a different thing altogether. Implant failure needing revision, this is soft bone. This is diseased bone. If you put metalwork into this, metalwork's likely to fail. Implants are not always the answer. And obviously, when you do surgery, major surgery, a treatment break is needed, meaning for the next few weeks, you might not be able to treat these patients. That needs to be factored in. There have been various guidelines about the role of surgery, and again, this one was from the Myeloma Working Group in 2013. They've updated it more recently. I think they really touch upon a couple of things, that spinal cord compression, severe spinal cord compression without neurological deficit, and if it's soft tissue disease, radiotherapy has a significant role to play rather than surgery. And you can see in the largest retrospective series, radiotherapy alone improved motor function in 75% of patients. We need to sort of dig a bit deeper into that data as well. Kyphoplasty, vertebroplasty is not the answer for spinal cord compression. It's answer for potentially pain, potentially preventing deformity. It's not the final answer, it's part of an answer. So why surgery? What is the role of surgery? I'm sort of talking again, myself out of business here, but there are certain little indicators where surgery may be helpful, and it's mainly when patient has spinal cord compression because of bone retropulsion, and even in that scenario, you may be able to actually treat them with bracing. If they have spinal cord compression with bone retropulsion and bad neurology, they're completely off their legs. That may be a small select group of patients where you may think about doing surgery. Again, that's the same thing. They're more updated. So I'm going to again steer away and say, well, we'll talk out of surgery. So this is another study with neurological outcomes purely for after radiation therapy for spinal cord compression, and just not any spinal cord compression, severe spinal cord compression. And again, if you start looking into this, it says 34% had no improvement, 27% deteriorated. That again sounds like, that doesn't sound good. But if you look into the paper more, again in detail, 100 patients who had minimal or not much deficit, but with severe spinal cord compression, so really bad compression, when they were given radiotherapy, only 14% went on to deteriorate, and even those did not deteriorate significantly enough to lose mobility. So if you catch them on time, probably surgery will be avoided. Then all of these case reports were littering literature about managing with bracing in the presence of instability. So I'm not talking neurological deficit. Patient has what we deem a badly unstable spine, is neurologically fairly intact. You'd think, oh, let's fix it, put some screws in there. But that's actually, there are multiple case reports that started coming out, and then more and more literature is coming out around this about how this can be managed non-operatively in bracing. So brace has a big role to play as well. Even in unstable spines, a highly unstable fracture, subluxation, bone is off the place, and it was non-surgically managed by a surgical team. So in reality, who ends up having surgery? So I kind of think, well, in my experience in the last few years, who's ended up having surgery? The first group is not uncommon. A patient presents, not known to have myeloma, middle of the night, and it's a weekend. They have severe spinal cord compression. They've got some neurology. And the surgical team either doesn't think of it as myeloma, or even if they do, they panic into doing something because the patient has bad neurology. So that's not uncommon. But more so, when someone has an established diagnosis of myeloma and they have rapidly deteriorating neurology. And what do I mean by that? So if someone's got a little bit of weakness, little bit of numbness, that doesn't really matter. However, occasionally we've had patients who said, I was walking yesterday, now I can't move my legs at all. Now that's where maybe, again, surgeons have to probably come into play. But even here, if it's pure soft tissue disease versus bone compression, we really need to think about that. So really, neurological deficit due to bony retropulsion, really. The second one is spinal instability, meaning they're getting more and more kyphotic in spite of bracing, and they're not really suitable for vertebroplasty. And why won't they be suitable? Because we think, oh my God, the cement's going to leak out in this one. We're really worried about this. So you might occasionally go and do. So role of bracing was, again, nicely described in this paper from Stanmore. Again, they divided patients into two groups, TLSO versus TLSO and kyphoplasty. It was all based on the SIN scoring system. And again, they showed that these patients could be managed properly with bracing only. Bracing is now increasingly an accepted part of treatment. We'll talk a bit more about logistics in a bit. But even if a patient has a vertebral compression fracture without spinal cord compression, for pain and pain only, you can think about a brace. To prevent deformity, you can think about a brace. But if they have spinal cord compression, they have stable neurology, still brace will work a lot of times. Obviously, yes, there are some gaps in evidence, but that will be addressed hopefully in the next few years. What type of brace? And there are various types of braces, TLSOs, CTLSOs. Do we use it for 3 months? Do we use it for 6 months? We don't know yet, but 3 months is a pragmatic answer. But at 3 months, you reevaluate them by doing a CT scan and an X-ray. And quite often you find that there is bone remodeling at that stage or early remodeling, and you can take it off. But sometimes you still panic because you haven't seen as much bone remodeling. You don't give up. Sometimes you carry on with a brace for a bit longer, but with close monitoring. And this is what a CTLSO looks like. Looks very comfortable, as you can see. And this is a Miami J, again, looks very comfortable. But you talk to a patient and they will actually tell you how uncomfortable it is. And patient compliance is an issue. So then come the practical aspects. When should the patient wear the brace? When should they take it off? Take it off for a shower? Can they take it off for brushing their teeth? Do they have to take it off in bed? All these things have to be considered. And you can't say the same rule applies to every patient. You have to individualize this. How frequently should they be imaged? 6 weeks? 3 months? There are questions to be answered there. And should the patient be completely immobilized, so in bed when the brace is applied? That means they need a lot of help for this, versus, no, actually they can apply it themselves with someone from their family. So there are challenges with bracing. As I said, compliance is an issue. Cost, yes, but we shouldn't worry about cost, but it is one, custom-made versus off-the-shelf, and then obviously radiological monitoring. There are gaps in evidence, and again, hopefully this proposed trial, hopefully it gets the funding, hopefully it provides some more answers and fill in the gaps there. Individualized plans are important. One plan doesn't fit all. Plans may change even for the same patient every few weeks. So as surgeons, I'm not ashamed to change my plan. That's part of my daily routine. So just very quickly, a few quick cases as to where surgery. So this is where I actually boast about what I did in my life. So this is a patient who's got soft tissue disease. He's saying, okay, let's manage him with a brace. He's got cauda-equina compression. This is going to respond really well to radiotherapy. But the patient, after 6 weeks of bracing, bed rest, everything, just couldn't get up, just couldn't. I mean, he was in the highest dose of opioids, pain clinic. He was being given ketamine here. So, and we thought this couldn't be dealt with vertebroplasty. So quick surgery, percutaneous surgery, so minimally invasive, 4 screws. So this patient was up and about day after surgery, so it makes a difference. So there is some role occasionally for the correct patient. Here, this one is a patient here who came to us 0/5 on a Friday. With, again, you can see there's a deformity, there is severe cord compression, and there is instability, and it's at the junction. So a lot of red flags here. And if you look at the CT scan, it's not just soft tissue disease, but there's bony retropulsion here. So this is the one I'm talking about, where actually, but it's not minor surgery. Look at all that amount that's gone in. It's morbid surgery for the patient. Patient recovered, thankfully, and neurology-wise, and this is what's happened to her a few months later. So you can see some of the bone remodel, some of it doesn't. This is an interesting one where a patient came in. Here, this is similar sort of scenario. He didn't have any neurology, normal, walking, just a bit of pain. And you can look at that. There's no bony retropulsion. It's purely soft tissue disease. However, this is what he ended up having. And that's partly because there are gaps in knowledge. Different surgical teams will treat this differently. There's not always, I'm not saying they're wrong, I'm right. I'm just saying this is what can happen. And this is what's happened to this patient a few months later. And they've had really good bone remodeling. But you say, okay, maybe this was the right thing to do. So sometimes needs dictate what happens. This was a pregnant lady, I think 30 weeks pregnant, who presented with this. Minor neurology, very, very mild numbness, and a lot of pain. And this is how the spinal cord looks. And obviously, this is a CT scan that was done after delivery, so it wasn't done straight. But just to kind of say, look, this is so. So what was done here was, you can't put her in a brace. You can't sort of start giving treatment, systemic treatment, till the baby's delivered. So steroids were given. She was put on complete flat bed rest. Baby was delivered. This was the CT scan. That's okay. She's neurologically intact. We've put her in a brace. And after 3 weeks, after 2 weeks of initial treatment, after the baby was delivered, you can see already there's a response to the disease. And she's doing pretty well. So bracing, radiotherapy, definitely takes precedence over surgery. And this is the last one before I end. On the right-hand side is a slide of a C3 vertebral body lesion. And this was flagged up. And then that happens 6 weeks later. Should we have put this patient in a collar? And we don't know. There are no answers for this. Does that mean every patient with every lytic lesion should be put in a collar? But then now, 6 weeks later, she has been put in a collar. So loads of questions to answer here, but you can see how remodeling happens. I guess I haven't given any answers, but raise more questions. Thank you.
Okay, so there was a disappointing lack of argument there. Everyone seemed to agree. So we're going to try to mix things up a bit. We've got a few case studies which are adapted from real cases from our MDT. In theory, you should be able to vote. So I'm going to go over here so I can see the slides. So what should happen is I'll present the case, and then there'll be some options up which you should be able to vote on in person and at home, and then we'll direct it towards the panel and open the floor for discussion. So the first one, 57-year-old woman comes in with new spinal cord compression. So she had myeloma that had been treated. It was in remission on LEN maintenance post-transplant, slowly rising paraprotein, but not overt progression at this point. Comes into A&E with back pain, bilateral mild leg weakness, no sensory loss. So an MRI scan of the spine was done. So these are pictures, but they might not be the most useful pictures, so they're for illustrative purposes only. Vertebral lesion at T10, resulting in potentially unstable spine and moderate to severe spinal canal compromise. So these are the 4 options that you've got. So number 1, emergency surgery, call your team, debulking and spinal fixation. Number 2, emergency surgery, and then follow that up with radiotherapy. Number 3, bed rest, steroids, and emergency radiotherapy, no surgery, and refer for bracing. Or option 4, bed rest, steroids, and then take her straight to chemotherapy with DVD, for example, followed by bracing. So in theory, we should be able to vote now. Does the screen change? Okay, have you voted? I don't know where I see the scores. Scores going to come up? Okay, so mainly radiotherapy. What have we got there? Very few people are going to recommend surgeries. I think Paraly's talked himself out of a job. Radiotherapy seems to be by far the most popular option. I think probably I'd be interested in what sort of para and Katie you've got to say about that, because I think practice probably has changed over the last 20 years, whether that would be in keeping with what you do at your centres these days.
I would agree. The only thing that made me slightly nervous was the comment on the MRI that it could be potentially unstable. I think I'd want to know a little bit more about the patient's symptoms, their pain, whether it sounded like instability pain or whether they were actually reasonably comfortable. I think if they were comfortable, then I'd probably be definitely going for the radiotherapy option. But if there was a suspicion that this might be unstable, then I think it would warrant discussion, at least with the surgeons, but I'd probably still be erring on the side of radiotherapy if we could.
Even if they've got pain, you can give them a bit of bed rest, brace them for a bit of time. As long as neurology is intact, and even if it's minor neurology, I think option C just literally works the vast majority of times.
Are there any comments from the floor? I can't actually see the online stuff, but anyone who is at a centre where that would be managed differently or sort of feels differently about the way we'd be managing that kind of case?
Okay, so the next case, 63-year-old man who's got smouldering myeloma and osteoporotic back pain. So this is a patient who doesn't have any of the CRAB criteria. So this is a real case that we had and we discussed at length in our MDT. He's had an MRI spine which shows multiple osteoporotic vertebral fractures, but no lytic bone disease. So osteoporotic fractures, normal hemoglobin, normal creatinine, normal calcium, got an IgG kappa paraprotein of 28, kappa light chains of 193, lambda of 7.9 with a ratio of 24, 30% plasma cell infiltration, so not meeting 60% that would put you into the slim diagnostic symptomatic category, no high-risk features, no other lesions. So no myelomatous lesions, but multiple osteoporotic crush fractures on the spine. So these are the options that we discussed. You could say this is smouldering myeloma, who's somebody who happens to have osteoporosis, refer to the rheumatology clinic for osteoporosis management. The other alternative is we would keep them in the smouldering clinic and give them a slightly more intensive schedule of zoledronic acid, so 3 monthly, for example. Some people might say that you could treat this as myeloma, full-on Dara-VTD, autograft Dara-VTD, Len maintenance, monthly zoledronic acid. Or you could sort of fudge it and say this is a high-risk smoulderer and going to give them a sort of lower dose treatment option with lenalidomide, dexamethasone, and zoledronic acid. So, vote now. Okay, so this is a bit more split as I thought it might be. The commonest response seems to be not related almost, that you've got somebody with smouldering myeloma who's got osteoporosis and they should be managed as per osteoporosis. And then the next most popular seems to be treat them with a slightly souped up zoledronic acid schedule. 12% would say this is myeloma and treat as myeloma, and then 10% would take that sort of Lendex option. So we discussed this, and I think all of these options were discussed. I think if I could ask Andy and Stella as sort of myeloma clinicians, what would your approach be, or what would you be thinking about when you're trying to come up with an answer for this question?
Well, I think I would treat as myeloma, to be perfectly honest. I think it's very difficult not to call this myeloma-induced skeletal disease. Osteoporosis is a feature, as are lytic lesions as well. I know the radiological appearances are different, but you've just got so much in favour of treating this guy. He's young, he's got a sizable paraprotein, he has definitely got skeletal disease, so I'd treat.
Yeah, and I actually agree. I think he probably has got myeloma, it's just you haven't been able to prove it yet. I would probably do another bone marrow because that might be a sampling error, and I'd probably do a diffusion weighted MRI to see how much infiltration.
We did that. That was negative, but
okay.
yeah, we tried that maneuver.
Or even a PET CT scan to see if there's increased activity. It's often very difficult with this group of patients, but I think, the other option would be to give Zamita and then wait, but watch them very closely, and if they get any more compression fractures, then move to treatment.
Are there any comments from the floor on that case? Yeah, Kerry. Oh, sorry, I think there's a microphone coming on.
I agree with Andy and Stella, and we've had similar cases in Cardiff quite recently and done the same thing. I guess one way of thinking about it is you can take the myeloma out of the equation, quote, if you treat that bit. The osteoporosis, if it exists on its own, obviously will need additional management. But these people can have awful spinal disease, and it does feel like the most beneficial thing you can do.
Question online. Andy, do you consider generalised osteoporosis to be caused by multiple myeloma?
Well, yes, they say it's the cardinal appearance is a lytic lesion and a pathological fracture. I think it is well recognised that osteoporosis is also present.
I think one of the issues is that the current formal diagnostic criteria for myeloma, they've taken sort of generalised osteoporosis out. You need to have sort of defined lytic lesions, which I think is probably why, I guess for trial entry, this patient wouldn't qualify because it doesn't fit those strict criteria. But some people would take the view that that's what's driving the process. Any other comments on that case? Yes, I think just wait for the mic.
I suppose there is an association, isn't there, between MGUS and osteoporosis and an increased incidence. So I guess on the extension of, I mean, you wouldn't clearly treat an MGUS with osteoporosis. And I know this patient has got myeloma, but equally, I guess there's a different, there obviously is some impact on the bone from the plasma cell dyscrasia. It doesn't necessarily warrant myeloma treatment.
I mean, I think for what it's worth, we took the view of close observation and 3-monthly Zometa, but I think there is a likelihood that he may well need treatment. I think probably one of my, just playing devil's advocate, I think once you pull the trigger and call somebody myeloma, then they're effectively on myeloma treatment for the rest of their life. So this patient would go on to Dara-VTD autograft, Len maintenance, and then as soon as then you're going to be treating and retreating based on paraprotein rises. So you're basically committing this patient to a lifetime of treatment. It's not just a discrete course anymore, which I think is another thing that sort of coloured our judgment when we were discussing the case in the MDT. Okay, next patient, 43-year-old woman with an L5 plasmacytoma and low-level bone marrow infiltration. So this is somebody who came in with lower back pain for 6 months, referred to the spinal surgeons, didn't come to us initially. They arranged a scan and a biopsy. An L5 vertebral biopsy showed a plasma cell neoplasm, so that was very clear. The rest of the results were less clear. So hemoglobin 114, creatinine of 61, calcium of 2.43, relatively high paraprotein of 18, light chain ratio of 8.8, kappa light chains of 167. Bone marrow showed just 5% plasma cell infiltration, so very low level, but something was there clonally, but less than 10%. And again, image from head to foot, no other lesions were present. So this is somebody who's really presenting with a primary large lesion, but when you look carefully, there's something in the bone marrow, but not at 10%. So these are the options that you've got to choose between. Number one, treat it as a solitary lesion with radical radiotherapy and then observe. Number two, give a low dose, palliative dose. So I think I might get told off for calling this palliative, but Katie can sort of correct me, and then observe. Number three, give a lower dose of radiotherapy, but then start myeloma-based treatment anyway. Or number four, start chemotherapy for myeloma and just serially observe that primary lesion. So, again, no correct answers. Vote now. Okay, so these are the scores. It's quite split here, actually, interestingly. So about half of you would go for radical radiotherapy and just observation, whereas a slightly lower amount would give lower dose of radiotherapy, but then start systemic treatment anyway. Fewer people are recommending just palliative radiotherapy or no radiotherapy at all. So I guess this question comes down to, do you believe in the entity of salutary bone plasmacytoma with minimal plasma cell bone marrow infiltration, which sort of is there on some lists, but always seems a bit nebulous? Katie, if you've got a view on this from a radiotherapy point of view, then maybe Andy or Stella can talk about, do you call this myeloma or not?
I think from a radiotherapy point of view, there's a clear indication to treat. She's symptomatic there. And actually, in the context of such low-level bone marrow disease, we probably would want to be doing more than just a single 8 gray. You could argue whether 30 and 10 or a proper radical course at 45 and 25 would be more appropriate, and I think there'd be discussion amongst us as a clinical oncology group to say, well, what do we think? We know this lady's chance of progression to fully blown myeloma is going to be about 50% at 2 years at least. So actually, whether 30 and 10 is under treatment is probably unrealistic, but I suspect we probably end up treating radically and then observing, but open to discussion on that. I certainly think that she would warrant more than a single 8 gray, to be honest.
Okay. And Andy or Stella, would you call this myeloma and then start systemic treatment afterwards or not?
It's very borderline. I think I would go with radical radiotherapy and close observation. It depends how you define myeloma. They're clonal cells, albeit only 5%. But for reasons that you said last time, Jonathan, once you start treating, you're on the runaway train, and you have an opportunity to cure this with radical radiotherapy. So I think that's what I would do.
No, I agree. I would probably go for option 1, but she is going to relapse. I mean, for certain she's going to. So the question is, you need to talk to her about that and whether actually she doesn't want to take that risk and start treatment early. But that's just one possibility, is to allow the patient to have a very important view about it, because it's going to come back again. This is just the beginning, as it were.
Any questions or alternate views from the floor or online? Yes.
I opted for option 3, and the reason is that I believe this lady has a myeloma clone that has gone beyond what we consider MCAS or smoldering. And we have seen patients that we treated with radical radiotherapy, and soon thereafter they had relapsed with aggressive disease. So the fact is that the biology of the disease of this lady has changed now. It's not something that we can manage as MGAS systemically, and needs to be treated as myeloma.
Okay, thank you. And I'll just move to our final case. So this is a 68-year-old man who's got myeloma and vertebral collapse. So known smouldering myeloma, under observation, and then unfortunately he came in with lower back pain. MRI spine showed new superior end plate fractures, T12, L3, L5, due to underlying lytic bone disease. No cord compression risk, so that wasn't a factor. Again, the rest of his parameters were fairly unremarkable: normal hemoglobin, creatinine and calcium, detectable paraprotein, light chain ratio was there, high-risk features. So I think we made a decision to start systemic chemotherapy. The question was management of the spine. So these are the options that could be considered. Kyphoplasty, I guess multi-level or single-level kyphoplasty, conservative management with a spinal brace, kyphoplasty, then a brace, or is there any role for radiotherapy? So those are the different options. If you could vote 1, 2, 3 or 4 now. Okay, so brace is a clear winner there, but some people are suggesting a kyphoplasty, and there's about 20% of patients who think there might be a role for radiotherapy. So I guess, Parag, if I could start with you on this one, kyphoplasty. As you mentioned, there seems to be kind of like fashions in spinal management. Kyphoplasty was big in the 2010s. It seems to have gone out a bit. What would you think there's a role for kyphoplasty here?
Is that 0% multi-level kyphoplasty?
Sorry, the multi-level kyphoplasty was 0, that's right. But then there's 16% of kyphoplasty then brace.
Okay,
So there are some people who still think it would be useful.
Because if you do a kyphoplasty at T12, L3, L5 levels in between come under a high amount of stress, which will then, those levels are not diseased, they just haven't collapsed yet. So you can't kind of think along those lines. So again, I'm very simple, I'll just think along these lines. Spinal brace is not unreasonable, or you could do another thing, you could do just a T12 kyphoplasty to make sure that level doesn't kyphose because it's at the junction. Then put the patient in a brace. And as you said, you could still, for pain, give radiotherapy to the other 2 levels. But yeah, I would have probably gone for a single level kyphoplasty and a brace with always to brace in these options.
And Katie, the role of radiotherapy here, so no cord compression, but just painful lytic lesions causing collapsed vertebrae.
Yeah, we were getting our story straight, so I agree. I think if there's a role for kyphoplasty for the sort of structural integrity side of things and bracing, but if rightly, you can't treat all of those levels of kyphoplasty, then if the patient doesn't improve with the brace, then radiotherapy certainly would have a role for pain control, and a single fraction would be entirely reasonable.
And I guess just before we finish, just out of interest, could we just have a show of hands who here has got access to spinal bracing at their centre? We've talked about it quite a lot, but I'd say that's about 20%. So, I mean, I guess there's quite a big difference between...
Can I just say one thing? That is that if the trial goes ahead and we get the funding, there's going to be an MDT, access to a rapid MDT more than once a week, so you will get a spinal opinion immediately, or fairly quickly, and also anyone with obligation to have bracing, i.e. instability, would be excluded. So it is only the safe group of patients that you would be bracing in the trial, as it were.
So I think we'll probably have to stop there. I'd just like to thank all the panellists again. Just in conclusion, I mean, I think there's a lot of consensus on some things. There also seems to me that large areas where there's just an absence of sort of randomised clinical trials, and I think the kind of initiative that's been put together by the UK group could be able to look at some of those very simple questions in an effective way. So I'd encourage you all to support those. And thank you again to all the speakers on this panel. So we're running a bit late, but I think if we can come back at 11:45 for the abstracts, please.